Hello, my friends. I'm Dr. Linda Parker, urologist and senior health specialist. And today we're going to talk about something that almost nobody explains clearly, even though it affects millions of older adults every single day: the quiet link between certain blood pressure medications and fall risk. Here's the myth I want to break right away. Most people assume that if a medication lowers blood pressure, it automatically makes you safer. Safer heart, safer brain, safer future. But the body doesn't work like a simple math equation. Blood pressure is not just a number. It's the pressure that keeps oxygen moving to the brain when you stand up, when you bend down, when you get out of bed at night, when you take a hot shower, when you're dehydrated, when you've been sitting for a while. And when that system is pushed too low, too fast, or at the wrong time of day, the price is not always chest pain or a warning sign. Sometimes the price is a fall that happens in the bathroom at 2 a.m., a fall that breaks a wrist, a hip, or confidence, a fall that makes someone afraid to move freely again. So, in this video, I'm going to show you 4 common categories of blood pressure medications that can increase fall risk in older adults, what to look for on your label, why it happens inside the body, and the simple checks you can do starting today to protect yourself or someone you love, without fear and without guessing. This is not about stopping your medication on your own. This is about understanding what you're taking, noticing patterns your body is already giving you, and knowing exactly what to discuss with your clinician so your blood pressure plan protects your heart without stealing your stability. Now let's talk about the real-world problem that people rarely connect. If you've ever stood up and felt a brief wave, like the room shifts for a second, many people shrug it off. They call it getting older. Or they call it just standing up too fast. If you've ever felt unsteady in the morning, especially right after waking up, that matters. If you've ever noticed you feel fine sitting down, but slightly off when you start walking, especially after meals, after a hot shower, after exercise, or after you take your pills, that matters. If you've ever had that moment where you reach for the wall or the countertop just in case, that matters. Falls don't always start with dramatic dizziness. A lot of falls start with subtle instability, a delayed brain signal, a slower correction, a small dip in blood flow, a moment of blurry focus, a feeling of weakness in the legs. And here's the hardest part. Many people who fall don't feel sick beforehand. They just feel normal. Until they don't. Blood pressure medications can contribute to falls in a few predictable ways. They can drop blood pressure too low when you stand up. They can increase urination and dehydration, lowering blood volume. They can slow the heart's ability to respond quickly when posture changes. They can cause electrolyte shifts that weaken muscles or alter rhythm and balance. They can amplify sedation, especially when combined with other common medications. And the risk becomes even higher in very common situations: older age, diabetes, neuropathy, dehydration, low salt intake, hot weather, alcohol, infections, poor sleep, and nighttime bathroom trips. So let's go into the 4 medication types you're most likely to see on a label and why they can raise fall risk. The first group is diuretics, often called water pills. On the label, you might see names like hydrochlorothiazide, chlorthalidone, furosemide, bumetanide, torsemide, or sometimes spironolactone. Diuretics lower blood pressure by reducing fluid volume in the body. That can be very useful. But it can also create a very specific fall pathway, especially in older adults. When you lose more fluid through urination, you reduce the amount of blood returning to the heart. Less volume means less pressure available during quick position changes. So when you stand up, gravity pulls blood downward, and there isn't enough reserve to keep the brain fully supplied. That's when people feel lightheaded, wobbly, or suddenly weak in the legs. But the fall risk doesn't stop there. Diuretics can also shift electrolytes like sodium and potassium. When electrolytes drift too low, people often feel fatigued, shaky, crampy, or mentally foggy. Those symptoms can be mild, and people push through them. Yet that mild weakness can be exactly what turns a small misstep into a fall. And then there's the nighttime effect. Diuretics often increase nighttime urination if taken too late in the day. And nighttime bathroom trips are one of the highest risk moments for falls. Dark room, sleepy brain, sudden standing, quick walking, sometimes urgency, sometimes a little dehydration from the night. If you're taking a diuretic and you notice any of these patterns, it's a signal worth taking seriously. You feel worse in the morning than later in the day. You feel lightheaded when standing up after sitting. You have more leg cramps, more fatigue, or more heaviness in the legs. You wake up multiple times to urinate, especially if the diuretic is taken later. You feel thirsty often, or your mouth feels dry frequently. The practical move here is not panic, it's precision. If you take a diuretic, check the timing. Many people do better taking it earlier in the day. If you're already doing that and still waking up multiple times, that's a conversation to have. Also check the two-number pattern on your blood pressure readings, the top number and the bottom number. If your blood pressure is controlled but you're diastolic, the bottom number is getting very low, especially in older adults. Some people become more prone to dizziness. That's individual, but it's a pattern worth noticing. And if you want a simple self-check, do this safely. Sit on a chair for 2 minutes, then stand up slowly. Notice, do you feel a wave, a dip, a blur, a need to grab something? If yes, record it. Because symptom patterns are powerful when you bring them to a clinician. The second group is alpha blockers. This is a big one because many people don't even realize they're taking one, and in men it is often prescribed for urinary symptoms. On the label, you might see doxazosin, terazosin, prazosin, or tamsulosin. Even though tamsulosin is often discussed for urinary flow, it can still affect blood pressure regulation in some people. Alpha blockers work by relaxing blood vessels. That reduces resistance, which lowers blood pressure. But the trade-off is that it can impair the body's ability to tighten vessels quickly when you stand. That quick tightening is what keeps blood from pooling in the legs. When it doesn't happen, blood pressure drops at the exact moment you need stability. This is one of the most classic causes of orthostatic hypotension, blood pressure that drops when you stand up. People describe it as, I stand up and my vision goes gray for a second. I feel like I'm about to faint, but it passes quickly. I feel fine, then suddenly weak when I start walking. I get dizzy after bending down to tie my shoes. I feel unsteady in the shower. Alpha blockers can also have a first dose effect, where the very first dose causes a stronger drop. That's why many clinicians start at night. But nighttime dosing can also be risky if it increases nighttime dizziness on bathroom trips. So the key here is awareness and strategy. If you're on an alpha blocker and you've had near fainting moments, frequent dizziness on standing, or a recent fall, this medication category deserves a careful review. That review can include dose, timing, and whether it's necessary to keep the same medication versus a different approach that controls symptoms without compromising stability. Also, pay attention to stacking. If someone is on an alpha blocker plus a diuretic plus another blood pressure medication, the combined effect can be much stronger than any one medication alone. And that's often how fall risk sneaks up. Not one medication, but a combination that lowers pressure in multiple ways at once. The third group is beta blockers. On the label, you might see metoprolol, atenolol, bisoprolol, carvedilol, propranolol, or nebivolol. Beta blockers are used for blood pressure, heart rhythm issues, chest pain, and heart protection after certain cardiac events. They can be very helpful. But they can also raise fall risk in a specific way. They can blunt the heart's ability to respond rapidly when you stand up. Normally, when you stand, your nervous system says, "Okay, we need a quick adjustment." Heart rate rises slightly, blood vessels tighten slightly, pressure stays stable. Beta blockers can limit that response. That means blood pressure can dip and the body can't compensate as quickly. In real life, that looks like you stand up and feel slow, heavy, or a little faint. You get tired faster when walking. You feel your legs don't wake up quickly in the morning. You feel more unsteady when you've been sitting a long time. You notice cold hands and feet along with fatigue, which can reduce confidence in movement. Another key point: beta blockers can contribute to slower heart rate, and a slower heart rate can sometimes correlate with reduced tolerance for sudden posture changes. Now, not everyone experiences this. Many people do well on beta blockers. But fall risk increases when beta blockers are combined with dehydration, low food intake, alcohol, heat exposure, or other medications that also lower blood pressure or sedation. So what's the practical move? If you're on a beta blocker and you notice fatigue, lightheadedness, or reduced exercise tolerance that wasn't there before, bring that pattern to a clinician. It can be a dose issue. It can be timing. It can be an interaction with another medication. And here's a simple behavioral safety move that can change everything. When you wake up, don't stand up immediately. Sit on the edge of the bed. Take 20 to 30 seconds. Move your ankles. Flex your calves. Then stand. That small pause allows circulation to stabilize before you start moving. The fourth group is medications that can cause stronger drops in pressure, especially when combined with dehydration or other medications, most commonly ACE inhibitors and ARBs, and in some cases calcium channel blockers. On the label, ACE inhibitors include names like lisinopril, enalapril, ramipril, benazepril. ARBs include losartan, valsartan, olmesartan, irbesartan. Calcium channel blockers include amlodipine, nifedipine, diltiazem, verapamil. These medications are widely used and often very beneficial, especially for long-term cardiovascular protection and kidney support in some patients. So why mention them in a fall risk video? Because in the real world, the fall risk doesn't come from the medication being bad. It comes from the pressure going too low in certain situations, especially in older adults who are more sensitive to volume shifts, meal-related drops, and heat. Here's what happens. ACE inhibitors and ARBs lower blood pressure by changing vessel tone and the hormonal system that helps retain sodium and water. When someone becomes dehydrated after vomiting, diarrhea, fever, poor fluid intake, or heavy sweating, these medications can amplify the drop. That's why clinicians sometimes tell patients to temporarily hold certain medications during acute illness. Not everyone gets that advice clearly, but the concept exists for a reason. Calcium channel blockers, especially those that relax blood vessels, can cause swelling in the ankles and can also contribute to dizziness in some individuals, particularly at higher doses or when combined with other medications. Diltiazem and verapamil can also slow heart rate in some cases, which can overlap with the beta blocker effect on compensation. The fall risk pattern here is situational. People often feel fine most days, then have a bad day where they feel off, wobbly, or dizzy, and it turns out they were a little dehydrated, skipped lunch, had a hot day, took a new medication, or had a glass of wine. So the practical move is to identify your triggers. If you feel dizzy most often after meals, that could be post-meal blood pressure drop, which is common in older adults. It's not just the medication, it's the combination of digestion pulling blood into the gut, plus medication lowering vessel tone. If you feel dizzy, most often after hot showers, that could be heat-related vessel dilation plus medication. If you feel dizzy during an illness, that could be reduced fluid volume plus medication effect. And if you're seeing swelling in the ankles with a calcium channel blocker and also feeling unsteady, that's worth discussing, because sometimes an adjustment improves both comfort and stability. Now I want to give you a simple, practical framework that turns this information into action. Because knowledge without action doesn't protect you. Here are the 4 steps I want you to take, starting today in a calm and organized way. Step 1. Check your label with purpose. Look for any of these categories: a diuretic, water pill, an alpha blocker, a beta blocker, an ACE inhibitor, ARB, or calcium channel blocker. Write down the names and the times you take them. If you're helping a parent, take a picture of the medication list and write the timing next to each one. Step 2. Match symptoms to timing. For the next 7 days, notice when you feel the most unsteady. Morning, right after waking. Within 2 hours after taking medication. After meals, after a shower, after alcohol, during nighttime bathroom trips. You don't need complicated logs, just a simple note. Lightheaded at 9 a.m. after meds, or wobbly after dinner, or dizzy after shower. Patterns are what clinicians can act on. Step 3. Do a safe posture test. This is not a medical diagnosis, it's a clue. Sit quietly for 2 minutes. Stand up slowly. If you feel dizzy, weak, or you need to grab something, that's a sign to take seriously. If you have a home blood pressure cuff and you want to be more precise, you can measure blood pressure seated, then again after standing for 1 minute and after 3 minutes. Large drops can indicate orthostatic hypotension. If you ever feel like you might faint, sit back down immediately. Step 4. Bring the right questions to your clinician. Instead of saying, "My medication is making me dizzy," which can sometimes get dismissed, ask questions that guide a safety review. "My blood pressure is controlled, but I'm having symptoms when standing. Can we check for orthostatic hypotension? Is my current regimen too strong for nighttime safety? Can we adjust timing so I'm less likely to feel unsteady in the morning or at night? Are any of these medications increasing urination at night and making falls more likely? Are my electrolytes okay, given I'm on a diuretic? Do any of my other medications increase sedation or dizziness when combined with these?" That last question is crucial, because many falls are not caused by blood pressure medications alone. They happen when blood pressure medications combine with sleep aids, anxiety medications, certain pain medications, some allergy medications, or even alcohol. Now, I want to add something that often gets overlooked: the confidence factor. After a fall, or even after a near fall, people start moving differently. They become cautious, they shuffle, they avoid turning quickly, they stop walking as much, they start holding furniture, they stop going out alone, and that loss of movement can start a downward spiral. Less strength, less balance, less circulation, more stiffness, more fear. So fall prevention is not just about avoiding injury. It's about protecting independence. It's about keeping your body confident in space. That's why this conversation matters. Let me share a quick story that I've seen many versions of. A woman in her early 70s told me she suddenly became clumsy. She wasn't clumsy her whole life. It started in the last few months. She had 2 near falls and 1 actual fall in the kitchen. Nothing broke, but she became afraid of moving quickly. When we looked at the pattern, it wasn't random. Her diuretic had been increased. She started taking it later because mornings felt inconvenient. She was also drinking less water because she hated waking at night to urinate. Then summer heat arrived, So she was taking a higher dose of a water pill later in the day, drinking less, and walking to the bathroom at night in warm weather. That's not clumsiness. That's physiology. When the timing changed and hydration became more strategic, her clumsiness improved, not because she became younger, because the system stopped being pushed beyond what it could safely compensate for. And I've seen the same story in men who are prescribed an alpha blocker for urinary flow. They take it at night. It helps the urinary symptoms. But then they stand up quickly at 2 a.m., and the pressure drops, and they stumble. Again, not weakness, not age, mechanics. Here's another example. A man in his late 60s started a beta blocker after a heart rhythm issue. His heart rate slowed, which was the goal, but he noticed he felt heavy in the mornings and slightly dizzy when standing. He thought it was anxiety. He thought it was stress. It was timing and dose sensitivity. With the right adjustment and the right morning routine, he stabilized again, and his confidence returned. What I want you to take from these examples is simple. The goal is not to fear medication. The goal is to personalize it. Because two people can take the same medication and have completely different fall risk profiles depending on hydration, diet, timing, other prescriptions, sleep, and nervous system sensitivity. Now let's lock this in with one clear sentence that you can remember. Blood pressure treatment should protect your heart and also protect your balance, because stability is part of longevity. And I want you to feel hope here, not anxiety. Because most fall risk patterns are not mysterious. They are predictable, they are adjustable. And the moment you start paying attention to timing, symptoms, and posture changes, you become far more in control. You're not helpless, you're informed. So here's what I want you to do next. Tonight, take 60 seconds and check your labels. If any of those medication types are on your list, don't get scared. Get curious. Notice your timing, notice your symptoms, and start those small safety routines. Sitting before standing, turning on a light for bathroom trips, moving slowly after showers, and being mindful of dehydration. And if this video helped you connect dots you hadn't connected before, share it with someone who might be at risk. Falls are common, but they should never be treated as normal. And if you want more clear, practical guidance like this, especially for blood flow, urinary health, and stability in the later decades, make sure you're subscribed because we keep these conversations honest, simple, and useful. Educational content only. If you have persistent dizziness, fainting, chest pain, or repeated falls, please seek in-person medical care promptly because those symptoms deserve direct evaluation.